Welcome to Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. Today, I'm joined by Mark Cuban, entrepreneur, investor, and co-founder of the Mark Cuban Cost Plus Drug Company. Today, we're going to talk about what's really happening underneath the surface of drug pricing, so transparency, market incentives, and PBM reform. And Mark, I know that you've probably answered a lot of the same questions again and again about cost plus. So we're going to try to dig in a little deeper into these issues of transparency and also some of the new things that cost plus is involved in. So thanks for taking the time. We really do appreciate it.
I'm happy to. I'm excited to be here.
Cool. Well, we'll start with an easy warm up, and that is, as you look back to the start of cost plus, what surprised you about the early response that you got, and not just from patients or consumers, but maybe from industry or from critics?
I mean, everybody just dismissed us. I was just some rich, famous guy that was going to come in and talk about changing healthcare, and then just be just one more rich, famous guy to fall out and accomplish nothing. And, I've been involved in industry disruption before. And what I saw very quickly was that this was going to be the easiest industry I've ever been involved in to disrupt. It literally, because it's such a simple business, that the economics of healthcare are, put aside the care part, that's hard, right? But the economic side effectively is simple. What does it cost? How do you pay for it? And who takes the risk for unpaid costs? That's it, right? And what nobody knew was, what is the cost?
Right.
Just the most simple element. What does it cost? And so when we started Cost Plus, it was January of 2022. We had 111 drugs. But the smartest thing that we did was publish our price list so that anybody could get it. You go to business.costplusdrugs.com. You can request it. We have an API, not as in a drug API, but as in a programming interface where we can feed you data every night. Just by being transparent, we turned upside down the information asymmetry that had been in place when it came to drug pricing.
In my company, so many times we've tried to do diagrams of, all the rebates and how drugs are priced. And, the way that you laid it out is very simple. The way it actually happens now is very complicated, right?
Yeah, but that's a feature, not a bug, to the companies that are introducing that complication, right? They don't want you to know. They don't, they want you to be afraid. They want you to think they're the ones that can solve the problems. They aren't. They are the problem.
So if you were mapping out cost plus across this sort of traditional pharmacy supply chain, like in a diagram, where do you think that the greatest friction or resistance actually sits?
Oh, that's easy, right? Our mission is to carry every single drug we're legally allowed to carry. We don't have nearly as many brands as we'd like to, simply because the PBMs, the big three or the biggest PBMs, realized that if we were able to work out deals with the big brand pharmacy manufacturers, and we published our actual costs like we do now, and only mark it up 15%, just like we imploded their specialty generics business, we would implode their entire pharmacy business, because brands really only available on branded. Deep rebates are only available on branded medications and specialty, but we'll stick with brands. And they're a mystery to everybody. And they game them. They have rebate GPOs, all these other games they play. And if we just broke through that and brought transparency to it and marked something up 15% instead of 100% or more, they'd be in deep shit. And so they have told the brand manufacturers that we'd like to work with, if they work with us, then they will see a reduction in the placements on their formularies across their entire portfolios.
So by 2030, who's in trouble? Who in the supply chain is going to be no longer economically viable?
Insurance companies and the PBMs that they own, and all the largest insurance company has 2,600 subsidiaries. that do $161 billion in intercompany transfers. That's 0.53% of American GDP, just in intercompany transfers. They have so much regulatory and scale capture of the healthcare industry that it needs to change. Look, I'm a free market guy, but we don't have a free or efficient market in healthcare right now simply because these companies are so big. They need to be broken up. Just like we broke up AT&T in 1984, these guys need to be broken up by vertical so that, their carrier business can be standalone, their provider business can be standalone, their PBM business can be standalone, other versions, other parts of their business can be standalone, and let them compete, right? And, the return would probably increase to their shareholders because, if you roll out, the big PBM from a carrier, the stock of that PBM, since that's where a lot of their profits are, is probably going to do better than the carrier's ups and downs. But that's not for me to decide. I just think that they have so much control over the economics of the industry that it needs to change.
I often wonder, how do we get here? I mean, AT&T is actually a really good example of what you're talking about. I mean, all the component parts eventually became the industry that we see today versus the behemoth that right back in the 70s. But I wonder how we got here. Not for us to answer today, but I mean, every one of the big insurance companies, they all have a PBM, right?
Yep.
I mean,
no one stopped them.
Right.
Nobody stopped them, right? Why wouldn't they do what they did? They have every incentive to do it. I mean, you get big enough so that people can't say no to you.
Yeah. It's sort of too big to fail.
Yeah, and look, it's not just one company, it's multiple companies, but they know how to divvy up the industry. And I'm not saying they collude, but there are things they won't do, and they all adhere to the same won't do's, right? The way they price, the PBMs aren't going to price at net, even though ESI says they're going to add an additional per employee per month charge to compensate for the lost margin, right? It's just there's certain things they won't do that distorts the economics and makes it so that their interests are not aligned with patients or doctors for that matter. I mean, you talk to independent physicians, those that own their clinics, they're just struggling to hang on. And a big part of that is, so if you follow me on LinkedIn at Mark Cuban or M Cuban, I've been engaging with doctors, particularly those that have, are independent or work in practices or have clinics, and they've fully and I'm just thinking about this in real time now because I just read a bunch of this morning. They are very analogous in how they're paid to independent pharmacies. So hear me out because I'm thinking of this in real time, right? So when you take a prescription for Eliquis, to use them as an example, it's a brand medication, to a local independent pharmacy. The independent the retail price of that Eliquis is about $600. The independent pharmacy probably paid $570. The only way for them to get their money back is by the insurance carrier reimbursing them at least $570. That's what they have in their cost of goods. They don't. They under reimburse them. And so that they lose money, they lose a whole lot of money on GLP-1s. And so what ends up happening is, since that's such a big part of the business and they're losing money on every script, either they decline to fill those and they send them to CVS typically, or they take the loss hoping to, sell enough toilet paper and Cokes to balance it out, and they don't. And so many of them are right. So many of them are going out of business. Analogous to that is what's happening in the reimbursements from carriers to those independent clinics and physicians and practices. They'll delay. Like, I got into this big discussion about why don't they use accrual accounting as opposed to cash accounting. And there were some IRS issues, but effectively it was, we don't know how much or when we're getting paid by the insurance carriers. Now think about that. You have a contract with them. You have a set price or, a calculable price for whatever service you're offering. a member of that insurance company comes in and says, hey, I need, my arm set or whatever it is, right? And you expect to get it, but in reality, they don't know if they're going to get paid the full amount. They don't know when they're going to get paid. They're talking about how it trickles in, 12% here, 30% there. That should be illegal. And so then you also see in parallel to that, certain of these carriers buying up providers
Right.
so that they own them.
United, of course, is the biggest one.
Right. Yep. I won't mention any names, but that's what they do. And now you also see where hospital systems, have associated insurance plans that try to stay vertically integrated, but where they use external, do the same things. And so the point I'm making in all this, the carriers, it appears to me, and I'm not going to give specifics because I'm still learning all this, but specifics in terms of the carriers, appears to me are trying to do the same thing to physicians and clinics and practices that they're doing to independent pharmacies, which is, underpay them to death. That is the underpinning of what's so up about this industry. That if the people who are closest to the patient, 3 feet away, 5 feet away at the counter from the pharmacist to the patient, the doctor with a stethoscope on the chest, right, can't get paid. And just to try to get paid on both sides, the paperwork is insane. The committees that you have to deal with to get approved by the 97-year-old veterinarian that, never practiced medicine in his life, but is in charge of the denial committee that you have to talk to overturn the denial, right? It just wastes time. The paperwork wastes time, wastes money, and makes it so patients get I don't want to say inferior care because doctors do a great job, but it makes it much more difficult for doctors. And you see and hear it every day. That's what you do, right? And so it starts somewhere, and it starts with who defines the cash flows. Whoever defines the cash flows defines the industry.
Well, a lot of that is the government, right? Medicare. I mean, huge payer on that
But
side.
but they pay on time though, right? Medicare Advantage and Medicare, two different things, very distinct, right? Medicare pays on time. There's no pre-auth denials. Now, you might not like what the prices are paid, and there's difference whether it's outpatient and inpatient, and the outpatient doctors get paid less, and we can argue whether or not that's fair. But what's more important, it's not really the government. Again, to me, whatever the government touches is almost always less effective and less productive, except in this case. Because what makes it so that Medicare rates are unaffordable is all the mishigash and all the paperwork and all the things that I just mentioned that create overhead cost and cash flow out for those same doctors who feel like they're getting underpaid by Medicare. And Medicaid, basically the same thing. Here's the price. You don't have to take Medicaid, right? Not all doctors take Medicaid, but if you're a practice that specializes in Medicaid, you can make real money. You can do well and control your own destiny in a big respect because not everybody takes it. And I'm not an expert in Medicaid. And again, we can argue on what the prices are, but my feeling is if doctors were independent and didn't have to spend most of their day with paperwork and hiring all these different people to deal with that, Medicaid would be very profitable. You just can't get there in the current system.
I'm dying to ask you this one question that I've asked on the show of other people before, but you're probably more qualified than anybody else. Can you think of any other industry with a pricing structure like this where people don't know when they're going to get paid? When they, as you say, where they can't implement accrual accounting because they can't match up time periods, right? They got to do everything cash.
No, this is the only one. And it's even worse than that, right? So I testified before the Senate Committee on Aging. And one of the points that I brought up is if you are a patient buying that Eliquis and you are in the deductible phase, well, let me take a step back. When there's a brand medication like Eliquis The cash flow process is the manufacturer of that medication sells the product to a wholesaler, and there's three big ones that dominate the industry, but they sell it at the retail price. That's where it all starts to fall down. Because if you're running a hardware store and the distributor that you buy your hammers from only buys at the full retail price, the $49 or whatever for that hammer, right? Now you're the hammer store and you buy at 5% less than that price, which is what pharmacies buy. So let's say $50, $2. So you're buying for $47.55, right? Um, there's no money, no margin to be made whatsoever. That's the way brand drugs are bought and sold in this country right now. And it trickles down to patients in that when they're in their deductible phase, because everybody else is paid really close to retail price, they get charged retail price as well during the deductible phase. So you're paying the $600 for your Eliquis until you meet your deductible. Insane. Excuse my French, fucking should be fucking illegal. But it's put in place by the carriers that own the PBMs that collude and have um, companies, joint ventures with those wholesalers. Any other industry, to your point, they're buying that Eliquis at 50% off or whatever the net price, whatever it is after fees and rebates, right? And then they're selling it to the pharmacy at a markup that makes them the same amount of money as they were before. Because when a wholesaler, to explain it more, when a wholesaler buys that Eliquis from Bristol Myers, and if it's $600 retail price, they get a 2.5% prompt payment rebate. So it's $600. So they're getting $15 back, 2.5%. And then they get another 1.5% for DSA, which is digital services agreement, effectively, right? So they're making 4 to 5%. That's it. So 4 to 5% of $600 is $30. If they would just buy it at $300 and mark it up $30 when they sell to the pharmacy, so the pharmacy was buying it at $330 and they could sell it to the patient for $350 or $375, whatever it is, and compete there. And so when the patient walked in during their deductible phase, it would be $375 instead of $600. Patients be able to afford their medication better. And it's all because these people don't give a shit.
Yeah. Yeah. What do you think? Well, I'm going to make a pharma argument because I've seen this industry for 30 plus years. My sense is that if we go back to, 90s or whatever, that pharma has been behaving like a scared cat. In other words, they go into these negotiations. Now they blame the PBMs, right? You've seen this, but they go into these negotiations, again, going all the way back to early days of managed care, and they say, well, we're not going to be able to get our drug on formulary unless we give a rebate, right? We have to. It's almost like pay to play, like shelf space.
Yeah, for sure. Yeah, that's exactly what it is. It's shelf space, auctioning off access to the formulary, right? And the answer to that is required. Again, it takes legislation. Require that formularies be segregated from PBMs. It's a different process.
Should be.
And it's changing enough now that Lilly's going direct, Novo's going direct, Bristol Myers Squibb is putting together a great program that they'll launch for direct, and so they don't want to deal with the PBMs. Lilly and Regeneron actually changed for their own employee benefits. They moved away from big three PBMs. Because 7-Eleven, Tyson Foods, a growing number of companies are doing that. But to your point, the pharma manufacturers are terrified. As I said earlier, the reason why Cost Plus doesn't carry brands is they're afraid of losing their positioning on the formulary. Make it so they're required to be disaggregated. Because for a big company to hire a consulting firm to look at and review their formulary annually costs less than $25,000.
Yeah, it's nothing.
No, and that's what I just got off the phone. That's why I was a little bit late. Talked to a huge company, and I told them, you're getting ripped off. and went through the whole long list of reasons, including why do you use them for your formulary? They're just auctioning it off.
Yeah. Yeah. Well, just sticking with this, and I want to get to the health systems here in a second, but
Sure.
just thinking about a lot has been talked about transparency. It's almost like a philosophy, but you're really using it as a signal, like a market signal, right?
Yeah.
To say, here's what you're going to pay, and upfront, this is what the cut that
And
we're
by the way,
taking.
here's our cost,
Right.
and here's our markup. Because what's missing more than anything on the economic side of the healthcare industry? Trust. And how do you
Yeah.
engender trust? You're completely transparent.
So now that you've been at this for a few years, what's the most interesting, say, behavior change that you've seen from either pharma or from employers? Just simply the fact that you're
By
publishing these
employers.
prices by
Yeah.
employers.
So, yeah, from employers. Like when I was testifying at Senate, so was Dr. Molds, who runs the CalPERS for California, for their people for their benefits plan. And he said he used our price list to negotiate with the big three PBM they ended up going with. I was like, well, I'm upset you used a big three PBM instead of using somebody who's more transparent. But he was like, no, you really got them to lower their prices and saved all of our members a lot of money because we were able to use you as a reference price. And it's one thing on tablets and pills, right? But it's a whole nother thing on biosimilars. So like we just released our biosimilar for Stelara. And Stelara was like $125,000 a year for the brand version. We're $410 times three, so $1,230 a year. The big PBMs, they're not now with their biosimilars. They've cut the cost from 125,000, but it may be 9 or 10 or 15,000 with some rebates versus $1,230. That's the biggest change because people are using our price list and realizing where the inefficient or where the ripoffs are from their PBMs and saying, you got to match cost plus. And oh, by the way, just because it's a biosimilar doesn't mean we're going to let you take advantage of us.
So do you see biosimilars as sort of being in your entree into the branded world and really expanding in that world of biosimilars?
Yeah, there's a couple different areas. One, we'll work with third parties to get biosimilars wherever we can. But we also do manufacturing for sterile injectables in Dallas. And right now we do generic sterile injectables, everything from Pitocin to pediatric cancer drugs for hospitals. And because they're on short supply, historically, those manufacturers have just jacked up the price. And so because we do our own manufacturing, it's all robotics driven in Dallas, our prices are dramatically lower. And we also have a wholesaler that we built, a virtual wholesaler, where we just do a cost plus markup as well for injectables and J-code drugs, biosimilars, and a growing number of other types of specialty drugs where we're able to save, like Penn Medical estimated we'll save them 4 to 5 million, CHS 1.8 million. I mean, honestly, and our business just keeps on growing by the week. And our hardest part of that business is getting the purchasing agents in those hospitals to change their behavior, even after they're told, right? But the bigger picture is in terms of employers. What has changed over the past 4 years is that at the beginning, it was easy for the big PBMs to dismiss us. They're small, they have no track record. And then, a year, 2 years later, it was like, okay, well, here's cost plus drugs price list. You got to at least come close. And the big PBMs would just increase the rebate. Okay, you got us, we'll increase the rebate. But now, sitting and talking to CEOs, they're starting to understand that your sickest employees pay those rebates, that there would be no rebates if nobody used a medication, right? And when you have tens of millions of dollars or smaller, whatever the number is that you're getting in rebates, your sickest employees and your most chronically ill employees are the ones that use the most expensive drugs with the biggest rebates. And they're the ones that are getting charged that full retail price during the deductible phase. And I sit with employers and the CEOs and I say, okay, do you know what the ERISA laws are? That you have a fiduciary responsibility to your members, particularly your employee members. And if you are charging them the full retail price for this specialty brand medication, so a big chunk of that specialty brand medication price is coming back to you in a rebate. So you are taking money directly from the employee. Now, the cash, as I said earlier, goes in a roundabout way, but effectively, the $600 check that the employee wrote, 300 of that, in an example, is going in rebates. The PBM keeps part of the rebate, and the rest goes to you. So your sickest employees are paying you those rebates. How's that going to look in an ERISA lawsuit?
I was just going to say, and I would think if you're talking to health system CEOs, they probably understand a lot of this. But out there, you're talking to CEOs, CFOs. Do they really understand kind of the exposure? Do they understand
No, that's
what you
why I have
just
to go.
explained?
No, they don't. That's why my meeting with them is what's changing behavior. So I go through my list. I just got off the one, like I said, before I came on this call. And their eyes just kept on getting bigger and bigger and bigger, and to the point they went, how it goes. You put your head down and you just start laughing because there's nothing else you could do. They're starting to realize now. And I go talk to CEO organizations and I go talk to benefits organizations. And so on the employer side, it's one thing. Then on the hospital side, it's a completely different beast where the hospital networks are both victim and predator.
What do you mean by that? Just their relationship to GPOs, or
No, not necessarily. No, put aside the pharmacy benefit on the medical side. Now, on the pharmacy side, they benefit more, right? The predator in that they take advantage of the 340B rebates, right? They create facility. Well, with J codes, they make, good money on J codes. When if it was part of the pharmacy benefit, it'd be significantly less for the member and the payer. So, you know, they're not completely innocent, but I think again, the insurance companies I'll give the networks, the hospitals, the benefit of the doubt and say that the plans that are designed and the way the economics are defined by the carriers puts the hospital networks in a really precarious place unless they have true market dominance. If the hospital has true market dominance in a market, all bets are off.
Mm. So you've used the term or the phrase tobacco style litigation.
Yeah.
What market trigger do you think could push? And let's set the politics aside, right, for a second. But
Mm-hmm.
what market triggers might push us into that territory?
Oh, just lawyers doing what lawyers do. Right? If I was an ERISA lawyer, oh my God, I'd be like looking at, yachts, 300-foot long yachts, it's just easy pickings. Just for the very reason I mentioned, if you are a CEO who signed a deal that made a patient pay list price during the deductible phase, and with a little bit of research, you find out that X% of your members can afford and didn't get care or didn't get their medication because it was double what it should have been.
And they can't just plead ignorance.
No,
Right.
no, they signed the agreement.
Right. Right. So let's talk a little bit about cost plus marketplace, because I think a lot of people think of cost plus drugs as like a consumer focus, but as we've been talking about,
there's a much more to it.
Much bigger than that. So talk to me a little bit about like the role where you sit and then the role of the GPO and kind of getting back into that, maybe some resistance on the part of health
Sure.
systems that you're talking to.
Look, the price is the price. It's that simple. And there's always going to be resistance. There's always going to be pushback from competitors that we're doing it the way it's always been done. And when we come in with Cost Plus Marketplace, and you can get access to it by going to business.costplusdrugs.com and just signing up, but we just show you our price. Show us your claims and we'll price it, and you can compare to your existing prices. Period. End of story. And if we're cheaper, we're cheaper. And if we're not, we're not. We're not asking for an exclusive. We're not saying you have to buy from us. We're not giving you rebates, right? All we're saying is, here's our price. It's up to you whether or not you want to buy. And we saved so many hospitals so much money that we had one of their GPOs threaten to sue the hospital. They can't sue us. We don't have a relationship with. Threatened to sue the hospital by sharing their claims, saying that was proprietary information. That's how scared they are of Cost Plus Marketplace. So go to Cost Plus Marketplace.
Yeah, right. Well, I mean, their whole business, the whole business model, the GPO model, I mean, it's kind of similar in the wholesaler model, right? They depend on having massive numbers of hospitals in the network. So they say we have this buying power. And if you're
Right.
eroding that, right?
Well, we're not eroding it. They're telling you by definition that they have all this buying power, right? Either they're passing it on to you and saving you a boatload of money. There's no good reason for a company with 70 people that's been, shipping for 4 years to be able to beat the prices that these GPOs negotiate for hospitals. There's no good reason on God's green earth why we should be cheaper unless those GPOs or however they're sourcing, whoever's doing the buying is putting that money in their pocket.
Yeah. Well, so if you become sort of a standard, say, procurement channel for these health systems, what goes away? Do the GPOs go away? Do some of the
No,
wholesalers
look,
go away?
we're non-exclusive, so they adjust. Look, my mission is to fuck up healthcare. If all of a sudden one of the big three PBMs, Mark Cuban's Cost Plus, where our costs are lower, we'll match Cost Plus 15%, which from their perspective, probably by definition, their prices will be lower than ours. Well, I won't go out of business. My business might get smaller, but there'll be a lot more happy patients. And it's the same with the hospitals and the GPOs. If they want to match our price, they can. They can beat our price. They're big enough to do it. It's up to them. And I think that's what happens next. They're not going to just go away. But as our volumes grow and our costs come down, the prices we charge, because it's cost plus, go down for patients and for the networks.
Mark, I could keep going, but I
I'm
want to have
ready.
you. I want to have you back.
No, we
this is
keep going.
great.
I got a few more minutes.
This is great. I'm wondering if once you get into, because it's coming, and as you said, we talked a little bit about biosimilars. Once you really start cracking into this branded volume, we'll say, or maybe you differentiate between the biosimilars and the pure brand products. But once you really start dipping in, and let's say you're getting at 5%, 10% of share of some of this branded stuff, what kind of reaction do you expect to see in the marketplace? You're going to see the big PBMs react, or you're going to?
Oh, of course, they react now. I mean, the CEOs of these PBMs talk shit about us all day, every day. Like they told one huge account, whose CEO I was speaking to, that our biosimilars only work 20% of the time. I
What?
mean, yeah, exactly. Right. Just complete nonsense and bullshit. That's what they do. And that's okay. Right. Because at the end of the day, it's about trust. When we first started, like we spend no money on marketing. Now I've got a big platform, but you'll never see ads for cost plus drugs because I wanted to keep the costs down. And when we first started, the people that we brought in, they're like, well, we got to advertise. I'm like, no, you don't understand. Our product is not drugs. Our product is trust. That's what we sell. Nobody trusts anybody on the economic side anywhere in healthcare at all. If we are completely transparent, they will trust us. And as we expand to different areas, corporate, wholesale to IDNs, our manufacturing, we'll win because we'll get the benefit of the doubt every single time, because the only reason somebody is competitive with us is because they were cheating their customers before and they had to change. And that it's hard to regain that trust. And we'll keep on. Look, we're working on the manufacturing that we have now is in Dallas, all AI and robotics driven. We're working right now to take that and create these pods that we'll put together that, based off our early numbers, we will be able to manufacture generic tablets in Dallas for the same price we're buying them from now. Now, somebody can mess with us with the API pricing, the KSM stuff could get finicky, but that would apply to everybody. The only thing holding us back there, honestly, and it's kind of crazy, is in order to get permission to manufacture each one of these tablets, you have to go through this ANDA procedure. And to do all the tablets we want to do would cost us $36 million to get all the ANDA approval. So we're trying to get some waivers there. We're not asking for any money for any of the manufacturing component side of it, but we want to be able to manufacture all drugs. And then on cost plus drugs, if we're able to get those waivers, because for 100 drugs to spend 36 million is almost impossible, right? So if anybody out there from the FDA, we want to hear from you. We want to pay, we'll let you come in and sit in our manufacturing, and you can watch everything. We're completely transparent. You can be there all day long, and all night long for that matter. But if we're able to do that, then when you go to cost plus, we'll put a little American flag next to the SKU and show that it was made in the United States, just like we do now we will for our sterile injectables, because, we want to be able to protect the supply of drugs for this country. And we think we have a path to do it, where everybody else who wants to manufacture, whether it's generics or whatever it may be, they want to build these huge, enormous plants to get up to scale. We took the opposite approach. It's all technology driven and it's all modular. So we just put them right next to each other, and we will get to the point, hopefully in the not too distant future, as in within 18 months, where we can do biologics. And I'm going to get all the terminology wrong. This is Alex's area, but we'll be able to do cell and gene therapies. And instead of charging $500,000 for, the first output from that therapy, hopefully we can get it down to $50,000. And instead of having to wait months, we can do it within hours or a day, so that we can take one of these pods, sell it to a research hospital, put it in the parking lot, and let's just say you have a very sick child and there's a gene therapy that you think will work. You give it to the child, doesn't quite work. You make a modification. You run it through the pod that we created, what we're calling the biopod, run it through the pod, and you get another bite at the apple, so that this one might work. And if that doesn't work, you try it again, so you can iterate in these drugs and save lives.
Wow.
That's all part of cost plus drugs.
Well, you really are disrupting. I mean, if you can be able to hit that market at those numbers.
That's because I have a brilliant partner. I wish I can understand the business side, and I understand. Alex is a rock star.
Well, last question. Do you see any logic in just dealing directly with the manufacturers? I'm sure you've had conversations.
Yeah, of course.
But what would that look like if you were working with Pfizer?
You're talking about from a patient perspective or
from a cost plus? From a cost plus.
Oh, we'd love to work them, because every single brand manufacturer we want to work with right now. The only reason we'll work the way they want to work with us, but they won't, for the reasons I mentioned. Those PBMs aren't going to give up without going down swinging. And I think the manufacturers are smart. As I said earlier, they're figuring out workarounds in their direct-to-patient, the LillyDirects.com, the BMS direct-to-patient, the Novo direct-to-patient. It's really smart because it gets them to work around the PBMs. And it also allows them to have direct contact with employers, because they'll do direct-to-employer programs, I'm assuming, and with the patient, because now, like, pick a company, your company, whatever PBM you guys work with for your pharmacy benefits. And by the way, I know you're going to go back and say they should change, right? And go to work with a pass-through PBM. They say on business.costplusdrugs.com, but you're not allowed. So if John wanted to talk to Lilly, or your employer wanted to put together a program with Lilly, your PBM agreement says you can't do that. Lilly doesn't even get access to the claims. Those brand manufacturers, they have to buy claims from the PBMs. And And so the employers, you would think the employers would want to be able to provide all claims associated with Lilly drugs. So Lilly and the employer can work together to, work on adherence programs, work on wellness programs, just work together relative to the population that that employer represents. Nope. Doesn't happen.
Well, I would be surprised if one of these upstart pharma companies launching their first drug, right? Maybe it's in a really specific area, doesn't go directly to you and say, we want to have exclusive distribution or exclusive,
We don't
right
even
from
want
the start.
exclusive. Yeah, we don't even want exclusive, right? I mean, we want to earn exclusivity. We'll take it, right? But we want to earn that exclusivity because I understand it, right? If the big three PBMs or big six PBMs cover 270 million lives, we're bupkis compared to that today. But every time we take 250,000 member lives at a big company and move them from a big PBM to a pass-through PBM, that's one brick out of the wall. And we remove another bricks, pretty soon we'll be singing, we don't need no education. We
All in
don't need
all,
no PBMs.
that's right.
All
We
in
don't
all,
know
the
the PB.
PBMs are gone.
Oh, wow. Well, this has been great. Let's real quick, Mark, let's do a quick lightning round.
Sure.
Five quick lightning round questions. One, most misunderstood part of the drug pricing system.
Wholesalers that
One,
they buy at list price.
very true. One thing every employer CFO should ask tomorrow.
Who pays the actual rebates? Why are there sick employees? Better yet, why are all their members paying full list price for medications during their deductible phase?
A healthcare company whose model, other than your own, whose model that you really admire right now.
Oh, there's a bunch of them. I love all the pass-through PBMs, Transparent, Sage, TPA, some of the DPC companies. There's a lot. There's a lot of people trying to do the right thing.
First rule that you'd put in place if redesigning the pharmacy benefit from scratch.
Segregate the formulary from the PBM.
Mark, this has been great. I mean,
I really enjoyed it. Yeah,
I've enjoyed it. I really want to have you back sometime.
Sure.
Keep us up to date on what's going on with Cost Plus.
For sure.
Really exciting times. Thanks a lot for taking time.
My pleasure. And I'll tell everybody out there, go to costplusdrugs.com, put in the name of your medication, see if we can save you some money or your patient's money.
Excellent.
Thanks for having me on, John.
Thanks. And that'll do it for another episode of Healthcare Rounds. If you like what you heard, please make sure to rate and review, and we'll see you next round.